First of all, I would like to thank you for this opportunity to join your meeting and for your efforts to contribute to human rights based approach in mental health care. Today is International Human Rights Day, and we know that many people worldwide still cannot enjoy their rights, and among them those who disproportionately suffer are many people with psychosocial disabilities and mental health conditions. So I would like to contribute to your meeting with my reflections, insights after having been for 6 years, from 2014 to 2020, United Nations Special Rapporteur on the right to health. This is a global mandate when a person is appointed by UN, and my mandate was right to physical and mental health. So I was reporting to United Nations each year, once to Geneva Human Rights Council, once to New York General Assembly. These reports are available in public domain. Also, I was traveling a lot and including official country missions to different countries in different regions, and then reporting again to Human Rights Council. And mental health and human rights was my priority, and everybody agreed with this, because, as you know, the good news during last, let's say, 15 years or so is that mental health finally is out of shadows and is a new priority. And everybody agrees that mental health should receive more attention, should be better funded. So this is easier part. And then a disagreement starts, and disagreement is about, so how we use these resources existing, and even if we are successful to have more, so how do we use? And there is a spectrum of very different views among experts. So there is a view that to stay with status quo, and status quo, existing infrastructure should just receive more money. And there is another view and increasing view among experts that we should move to other paradigm, as that already was happening in the history of mental health care and psychiatry several times in history. So I will not spend time on reminding history, but history is very, should we always read what happened, because history is repeating itself very often, especially if we do not learn from lessons. And in psychiatry, there have been a lot of tragic events when, with enthusiasm, some new methods were used, just forgetting to ask people if they agree. And they were done with good intentions, but you know what happened, like lobotomy, Nobel Prize, and then condemnation of this method, and many other examples. Just briefly about modern approach or human rights-based approach is that all forms of inequalities, discrimination, and violence have negative impact on mental health. So everybody will agree with this. And this means that states need to invest in enabling non-discriminatory and non-violent environments in all settings. What are the settings? The settings are family, school, workplace, community, but then healthcare services, including mental health care services. So they should be free from violence and discrimination. And we know that this is not the case. we have to always remind ourselves and important people like politicians about conventions on the rights of persons, Convention on the Rights of Persons with Disabilities, which is about dignity and autonomy, equality and non-discrimination, effective participation and inclusion, empowerment, respect for difference, for diversity, and that medical model, which is still dominating, is outdated model, because the new approach, the social model, tells that obstacles for realization to mental health or for any health are now not in the head of individual, not in his or her legs or body, but they're outside of individuals. These obstacles are created by society. They can be physical, but they can be go from stigma, from mentality. So these obstacles should be removed through empowerment, inclusion, participation, and non-discrimination. And so my first 3 years were a lot of meetings, a lot of travels to all regions, countries like high-income countries, low-income countries, middle-income countries, and looking for something which is common, so that I could reflect these issues in my reports. And I was collecting a lot of evidence about that there was no progress for the last 20 years in mental health care, that it was just dramatic increase of prescribing psychotropic medications, that it was pathologization of diversity, medicalization of feelings, and no progress in search of biomarkers. And so this crisis of biological psychiatry, which a lot of promises, as you know, 30, 40 years ago, there was a promise to reduce or eliminate stigma, just sending the message that mental diseases are the same as physical diseases. We just find good medications and fix these disorders with some biomedical discoveries. And this may be good, this idea, maybe it was good, but it failed. So, and coercion was on the rise, and coercion is still on the rise, including, as far as I know, in your country, but not only in your country. It's a global problem. Despite new investments, coercion, the cases of involuntary, let's say, measures is growing, and this is some signal. Another paradox is that European region, which is in general, let's say, not a poor region to compare with other regions, European region has highest numbers of children and adults who still live in large residential institutions. Maybe it's not the case of United Kingdom, but like Central Eastern Europe, where I live, is still full of large institutions, and they are funded by, international organizations, by national budgets. And so I came to conclusions in my reports. I very openly, critically addressed existing status quo and formulated position of the mandate that is absolutely unacceptable to proceed, to go on with such model, and to advertise, to promote this model to developing world. So instead of so-called global burden of diseases, you probably know there's very, very strong message from global mental health movement about global burden of diseases, and that we need to find each individual with mental disorder and to reduce treatment gap. This sounds maybe nice, but this leads to further medicalization. Instead, I suggested the global burden of obstacles, and I identified 3 main groups of obstacles, which is dominance of biomedical model and overuse of biomedical interventions. They may be needed, but they are overused, and this creates more harm than help. Then power asymmetries. In other fields of medicine, there is more or less already, partnership between doctors and patients, for example. The only exception is psychiatry. It's still paternalistic approach, and because of these power asymmetries, the users of mental health services are disempowered and not empowered. And then there is biased, one more obstacle is biased use of knowledge and evidence, when still we can read in the textbooks that biomedical model is effective. Like, for example, this issue of depression as effect of chemical imbalances in the brain. So, for example, in one of statements, I formulated that depression could be more about power imbalances, meaning social determinants of health and so on, inequalities, violence, discrimination. So depression may be, and other mental distress forms can be more about power imbalances rather than about chemical imbalances. And so this has led to many recommendations to global community, but especially to member states, to UN member states, to move to other models, to alternatives. Biomedical model can stay, but it should compete with other models, and other models should be liberated, and other models are not anti-psychiatry. They will help, I think, to improve image and reputation of psychiatry, and this is going on in the world, just maybe still is more like exceptions from the rule. And so I will not list all these my recommendations. You may find them, but you probably understand from this, let's say, the diagnosis of the system about these three main groups of obstacles: overuse of biomedical model, power asymmetries, and biased use of knowledge and evidence. From them we can move to recommendations that we should address and eliminate these obstacles. So one of issues for discussion, and these discussions are going on globally, and it's sometimes it's very hard talk between different experts, is the question, for example, I just raised for you to discuss, if not today, so next time, or with your politicians. So is it really, do we need a mental health law? Because mental health laws in all countries, they turn into discriminatory laws, because it is at least one article which would tell that it's possible to override the human rights of these people, and it can be very, very easily done because psychiatrists are allowed to tell that, this, for some reasons, this person can be, non-consensual measures in this case may be used. So maybe we don't need mental health law. Maybe we need general health law. In general health law, we know that if it is really emergency, like a person may die, maybe in some cases, like in car accident and so on, we should not ask informed consent. But if we stay with mental health laws, probably the discrimination will remain. And then these two so-called conventional wisdoms, which are still very widely used, and they do not have solid scientific basis. This is that non-consensual measures on ground of so-called dangerousness. This is a very weak and very vague argument. And the other is medical necessity, so that medical necessity, means if the person refuses to be treated, so we will do this by force. And now we know that these medications are not some miraculous medications. They may be helpful, but maybe they may have a lot of side effects and so on. So these are two weak arguments: dangerousness and medical or therapeutic necessity, and they should not be used so widely for non-consensual measures, for deprivation of liberty, which happens, as we know. Good news about the World Health Organization, because when I was reporting these reports, there was quite much of opposition and resistance from official psychiatry, but also from maybe WHO was not always happy that maybe it is too strongly told, But for example, in 2021, and I very strongly recommend this document for advocacy, but probably it's from June 21, WHO guidance on community mental health services, and recommendations are very strong, very modern, and there are 22 good practices from different countries, and these good practices signal that it is possible to help people with non-coercive practice. Just we have to be creative, innovative, and follow a human rights-based approach, fully embracing it and not in selective way. And there is also a very good WHO Quality Rights Initiative. But one of questions which I would like to raise to you, because we are the sad story, the EDENFIELD story happened in your country, in United Kingdom. So the role of developed countries, the role of countries to which other people, other experts are looking us to good examples, because many psychiatrists will ask from my region, from Asia, from Africa, they will come to professors in London and they will ask, shall we stay to status quo, or shall we move to other paradigm? So my idea is that United Kingdom should be one of those countries which shows example and very, let's say, strongly invests in all these alternatives, and not keeps just only to improving quality of existing services. So the very interesting debate about experts is in which countries it will be easier to implement innovative approaches. And one thinking is that, of course, in developed countries which have more money, and other experts will tell, no, it's much easier in Global South, because they do not have these sophisticated psychiatric services, which will be probably blocking these alternatives. So maybe the truth is somewhere in the middle. Anyway, there is a lot of challenges. It's a lot of tensions in this global debate, but also some hope, and I should say cautiously, but increasing hope, because there are increasing number of innovative approaches. So just to conclude, my final maybe observations should be that we all should invest in enabling and supportive environments in all settings, including mental health services. We should avoid over-medicalization, coercion, and institutionalization. And we should remind to everyone that too often people with mental health conditions suffer from all these outdated services and interventions more than from their mental health conditions. This is the most painful, ironical paradox. And persons with mental health conditions, as well as entire field of mental health and psychiatry, need to be empowered and liberated from this legacy of discriminatory laws, practices, and attitudes. So just to conclude, I like very much the sentence which was told by Jonathan Mann. He was famous doctor who was leader of human rights movement during culmination of AIDS epidemics. And I think if we add to mental health services very strong human rights component, we can be as successful as was this struggle to stop AIDS epidemics. And Jonathan Mann told the human rights framework provides a more useful approach for analyzing and responding to modern public health challenges than any framework thus far available within the biomedical tradition. So this is very important to know for medicine, for psychiatry, and I'm telling this with the background of medical doctor. And sadly, all these very sad things happen, which reach the level of atrocities sometimes in mental health services in the name of medicine and psychiatry. So this is very, very painful, and of course, this should stop. So thank you for your attention.